Yes, you're good to go.
Okay. So we are doing our presentation on substance abuse, and we're just going to go ahead and start. Okay. So we're just going to start with some definitions. So substance-related disorders are divided into two groups, substance use disorders and substance-induced disorders. So with the substance-induced disorders, they are also further subdivided into intoxication, withdrawal, and substance or medication-induced mental disorders. So your substance-induced psychotic disorder, bipolar-related disorders, depressive disorders, etc. With the substance use disorder, the DSM-5 recognizes 10 substance-related disorder classes, which include alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, and anxiolytics, as well as stimulants with tobacco and other. Each class of the above drugs has its own criteria set for a use disorder. The substance use disorders follows a standard set of criteria, so it requires 2 or more of 11 problematic behaviors which occur in a 12-month period, leading to a clinically significant impairment or distress. So the 11 symptoms involve overall groupings of impaired control, social impairment, risky use, and evidence of tolerance or withdrawal. And then this is also further rated for severity to mild, moderate, or severe. The prevalence and social impact in our society. So according to the WHO, harmful alcohol use was responsible for about 5% of deaths and 5% of the burden of disease and injury, which is equivalent to about 132.6 million disability-adjusted life years. Alcohol remains a primary substance of abuse in South Africa, and 1 in 10 deaths are associated with alcohol use. Between 7.5 to 30% of our population have an alcohol problem and are at risk of developing one. And currently we are ranked 6th in the world for the most alcohol consumption. Of those who consume alcohol in South Africa, 48% are men, and then 32% of that are women, who are it's often associated with binge drinking. Substance use is also further associated with increased exposure to violent crime as either victim or perpetrator of the crime, gender-based violence, unemployment, school dropouts, and being in conflict with the law. The etiology of substance-related disorders. So it's a combination of genetics, so the individual's biology, a person's environment, and the substance itself, which contribute to this disorder. Genetic factors are estimated to contribute as much as 40 to 60% of the variability of risk for addiction. Family background also plays an important role, and pharmacological properties of the drug itself contribute to abuse. For example, alcohol, opioids, anxiolytics can produce rapid relief of anxiety, which makes it quite desirable. Stimulants relieve boredom and fatigue. Hallucinogens provide a temporary escape, and these all contribute to misuse. The substances work, the addiction part of substances work with the rewards pathways of the brain. And it's the mesolimbic pathway is synonymous with the reward pathway. So the release of dopamine from the mesolimbic pathway into the nucleus accumbens regulates motivation and desire for rewarding stimuli. And this facilitates reinforcement and reward related to motor functioning learning. Also plays a role in the subjective perception of pleasure. And dysregulation of the mesolimbic pathway plays a significant role in development and maintenance of the addiction. So common substances have been shown to increase extracellular levels of dopamine within the mesolimbic pathway, and these activations are accompanied by the perception of reward. So this creates increased motivation to repeat the same behavior which caused it. So we're just going to give a quick case scenario in our presentation because it makes it easier to go through the management and approach to these type of patients. So this is a case of a 66-year-old male who's a known hypertensive on treatment, brought in to the emergency department by family members with a history of confusion, nausea, and vomiting. The significant findings on the examination was that the patient appeared dehydrated with a tachycardia of 115 and a low HUT of 2.6, and the smell of alcohol as well on the patient. The other systems examined well and were within normal limits. So the emergency management of the patient included fluid resuscitation and correction of the hypoglycemia. Further history from the family revealed that the patient has been drinking 8 to 10 beers per day since the passing of his wife. Also that he's lost interest in daily activities, struggles with sleep, is always irritable, skips meals often, and is poorly groomed. Also that he has had 2 previous similar presentations to the hospital in the past. So the next step. So in any setting, in an outpatient setting, especially when you are in a consultation with a patient, the CAGE questionnaire is an easy questionnaire to incorporate in your interview or consultation. It's quick and it's a screening tool used to assess presence of alcohol use disorder. Any positive response or overly defensive answer often suggests problematic use. And then as you can see, the CAGE questionnaire, I mean, the mnemonic sort of relates to the questions that will be asking. And then with the DSM diagnosis, so this is a little bit more in depth. So once you've realized that there is an issue, you can then go into, you can go into it a bit further and then to make a diagnosis basically. And in this case, we're using alcohol, the alcohol use disorder, the DSM-5 diagnosis. So it's, as we mentioned earlier, requires 2 or more of the 11 problematic behaviors which occur in a 12-month period leading to a clinical significant impairment or distress. And I'm not sure, I'll go through them quickly. I'll just summarize each point. So it's a maladaptive pattern of substance use leading to clinically significant impairment or distress as manifested by 2 or more of the following occurring at any time in the same 12-month period. So the first is alcohol is taken in larger amounts over a longer period than was intended, persistent desire or unsuccessful efforts to cut down, a great deal of time spent in activities necessary to obtain the alcohol, using alcohol or recovering from its effects, cravings or strong desires or urge to use alcohol, recurrent alcohol use resulting in failure to fulfill major role obligations at either work, school, or home, continued alcohol use despite having persistent or recurrent social interpersonal problems caused or exacerbated by the effects. Important social, occupational, or recreational activities are given up or reduced because of alcohol. Recurrent alcohol use in situations in which it is physically hazardous. Alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol. Tolerance as defined by either a need for markedly increased amounts to achieve the same effect or a markedly diminished effects with continued use of the same amount of alcohol. And then going into management, so we've just divided this into different levels of management. So we're starting with primary prevention of management approach. And this includes educational campaigns, community or family interventions, careful prescribing and education, legislation, and policing of illegal drug trafficking. And then secondary prevention. So this is early identification and effective management to prevent harm from substance misuse. And this can also be, the biopsychosocial approach can also be applied. So early recognition. So if a patient comes in and you recognize this as a withdrawal or delirium tremens in a case of alcohol, for example. So the symptoms of withdrawal range from anxiety, tremors, nausea, and vomiting to seizures and hallucinations. In delirium tremens, this includes confusion, agitation, perceptual disturbances, can have a mild fever, and autonomic hyperarousal. The management of withdrawals. So initially, it's just general supportive management, nutritional supplementation, including thiamine, folic acid, and multivitamin replacement, and the use of benzodiazepine. So the benzodiazepine of choice in alcohol withdrawal is diazepam. I've given it as we've given the dose as well. It's a 10 milligram stat dose, and then 5 milligrams in 15 to 30-minute intervals afterwards till the patient is calmed down. This can be tapered over a few days. Haloperidol is also used in patients who are having hallucinations, and that's 2 to 5 milligrams per day. In more specific cases, treatment of alcohol dependence in, as I said, carefully selected patients who are fully cooperative, the drugs like disulfiram, naltrexone, and acamprosate can be used. So for psychosocial approach, the depression and anxiety are often associated with substance use, and therefore it's important to identify the coexisting psychological illnesses and manage them. The involvement of a social worker and support groups also aid rehabilitation, and to put in place or ensure adequate support structures. So family and friends are often the support structures that we would like to have available. The challenges in our setting is that rehabilitation facilities are not always easily available and accessible at any time that we may need. For tertiary prevention, so it overlaps on the above. It's more about the inpatient care, managing the complications, also involves self-help organizations like Alcoholics and Narcotics Anonymous. Motivational interviewing has also been shown to help persuade patients to make their own case for change. So as you can see here, it's more about understanding a patient, listening to them, empathizing, listening without judgment, and empowering them to achieve goals and set goals and overcome barriers to them, without sort of playing an authoritative role and telling them, giving directives of what to do. Okay, complications of substance use, and in this case, we're going into alcohol use. So there's multiple complications, and we've grouped them into systems in this scenario. So these are include neuropsychiatrics like the Wernicke-Korsakoff syndrome, the alcohol-induced dementia, cortical atrophy, myopathy, depression and suicide, peripheral neuropathy and withdrawal. Under the gastrointestinal system, you get pancreatitis, liver disease, esophageal bleeds, gastritis, intestinal malabsorption. Cardiovascular patients often have cardiomyopathy related to excessive alcohol use. Malignancy, so there's oral cavities, esophagus, large intestine, liver and pancreatic cancers associated, and birth defects, other fetal alcohol syndrome that we know. The psychosocial complications, motor vehicle and pedestrian vehicle accidents, crime, increase of violence, spousal and child abuse, job loss, and divorce. So this puts a large burden on our healthcare system. The Wernicke-Korsakoff syndrome, so that's also something that's just like to note. It's a thiamine and B. It's a result of a thiamine and B1 deficiency secondary to excessive alcohol use. So though it's divided into Wernicke encephalopathy, which is confusion, ophthalmoplegia, and ataxia, and the Korsakoff psychosis involves amnesia, confabulation, and psychosis. And then these are just some of the references where we got some of the information, the DSM-5, some of the stats that we've used as well in our presentation. And thanks.
Nice, thank you. Well done. Any questions or comments? Let's just get your colleagues to just give you a bit of a rating. If you could just give them a sense of what you are. Any questions, any comments from anyone? Michelle, Dr. Kabir.
Hi, everyone. It's Michelle speaking.
Hi, Michelle, go ahead.
It's just more of a comment. I think you presented that well and you covered a lot of areas. I just think in terms of, we come across these things in acute and chronic care. There's so much mental health, so many mental health issues going on around us, and there's often an overlap between them. And I think it's just very important to have a really good approach in the primary healthcare setting, and to have kind of testing the mental health hypothesis high up on your list with patients, And just to recognize that there's often an overlap between your depression, anxiety, substance use disorders, sleep disorders. Often they somatize and get into these chronic fatigue kind of problems as well. And if you've just got a list of screening questions that cover those very common disorders, you won't miss it. But yeah, I just wanted to say that.
Yeah. I mean, if you look at, the DSM criteria, you can see that every Tom, Dick, and Harry in Africa, in South Africa, is going to be having a substance use problem, considering, the behavior around alcohol. I think one needs to just be very sensitive to it. And I think you've been spot on to focus on it. That alcohol is a really big problem, and it's a very difficult problem. So please don't think that it's something you're going to fix in a jiffy. And I think that's why the motivational interview, is the long haul. You've got to really stick it with the patient and work with them and not be judgmental about it. There are other problems, I think, growing substance use problems, probably substance abuse, more what's the drug that's out there? The HIV related drug. I'm somehow forgetting it, but anyway, I think the abuse in the community is growing, and I think it's a major problem. There's a very useful project in Questionnaire, which has got community-based efforts at rehabilitation, and I think it tries to skip the problem, Ashwarya, they point out, which is that there aren't very many support services in the community or in the Sapau Health Service to be able to support patients. I mean, if you're doing any withdrawal support, you have to really manage the patient in an inpatient setting, and that's not very easy to come by. You'll fill up quite a few hospitals, but nonetheless, this is some of the challenges you'll find quite common in primary care. As a general practitioner, you'll find these very challenging service issues around alcohol, because so many of the patients will come to you as opposed to what may pitch up at the public service. Thank you. Well done. And I'm sure great learning for everyone. So let's stop there. I think there are no questions at that. And we'll get the next group to